My name is Gloria Nashimba. Welcome to this roundtable episode. With Capital Radio, we are doing this work with the British government to highlight the works of the British government in Uganda. And we understand they've been doing some good work, tremendous work with the Mbarara University of Science and Technology. So this is part of the reasons why we are having these roundtable discussions. And my name is Gloria Nashimba. I'll be hosting this interview. I'll straight away come to Madam Vice Chancellor. Kindly introduce yourself to us, and after that, you'll answer the following question, which is what is the significance and scope of MAST's collaboration with UK research and academic institutions?
Thank you, Gloria. So I'm Professor Pauline Biachika Chibuika. I'm the Vice Chancellor of Mbarara University of Science and Technology. I'm a professor of internal medicine and epidemiology. Thank you for the question. You want to know the significance and scope of MAST's collaboration with UK research and academic institutions. Okay, so I'll speak a little about the collaborations. So MAST's UK collaborations are mostly postgraduate collaborations. So involving mostly students taking on postgraduate training, master's, PhD, and postdoc training. And of the collaborations and partnerships that we have with UK, the institutions include the Association of Commonwealth Universities that offers scholarships to MAST staff and alumni. We have the Royal College of Emergency Medicine that supports the Department of Emergency Medicine, where Daniel is from. We have the Royal Academy of Engineering that collaborates with the Faculty of Applied Sciences and Technology. The University of Southampton has exchange programs with the Department of Physiology. The Darwin Initiative and International Institute of Environment and Development that conducts research about conserving the environment in protected areas in southwestern Uganda. Then we have the London School of Hygiene and Tropical Medicine, the University of Edinburgh, Bristol Eye Hospital, and Moorfields Eye Hospital that collaborate with the Department of Ophthalmology. And the University of East Anglia under their School of International Development Partners that collaborate with the MAST Faculty of Interdisciplinary Studies. So these collaborations are all very important to us. The significance is that they enable us to train the students, as I said, at postgraduate level, but they're also partnerships for research and other initiatives, including community initiatives. But maybe to strengthen, to emphasize the significance in terms of the multiplier effect it has, because it's difficult for us to send several people over to the UK to train. But once one or two people go over to train, they come back and train several others. So that is a very significant contribution to MAST and to Uganda as a country. But also the research partnerships are very important because, we are a University of Science and Technology. And as a university, our major role is training, research, and community engagement. And these partnerships facilitate us to carry on our mandate of training, research, and community engagement. I'll stop there for now.
Thank you. And how impactful have these collaborations been in strengthening the university's overall capacity and its contribution to the country as a major institution of learning and training?
Okay, so as I said, the partnerships have facilitated us in terms of training and research. And a good example is the Department of Emergency Medicine that I'm sure Daniel is going to talk about very well. That is spearheading training of emergency medicine physicians in the country. But I also mentioned ophthalmology that he is going to talk about also. But also we have the Chevening and Commonwealth scholarships that have been of benefit to MAST staff and alumni through provision of opportunities for them to study in universities abroad, especially in the UK, gaining knowledge and skills that they can apply in various sectors, health sectors in Uganda. So overall, over 20 staff have attained PhDs and masters through the Commonwealth scholarships. And some of the beneficiaries are Simon here. He's going to talk about how he benefited and how he's translating this back to MAST and to the community in general. He benefited through the Commonwealth scholarship, and he became the first ophthalmologist in Uganda with a PhD. Simon, I hope I'm right.
Yes, you're right.
Yes, yes. So he's going to talk about his experience and what that has benefited him as an individual, benefited MAST as an institution, and the country at large. And he's using his expertise to conduct research and to do clinical training and service to the communities in the field of saving eyesight. A few others like Dr. Henry Lugobe and Penelope are Commonwealth scholars. They are also currently doing their PhDs in the fields of engineering. And this is at the University of London and University of Oxford. Then we have another Commonwealth scholar, Dr. Niwandinda Faith, who is also a beneficiary, who was able to train and obtain a Master of Science in Health Economics and Health Policy at the University of Birmingham. Faith is focusing on leveraging her experience and expertise in evaluating cost-effectiveness of healthcare interventions as a critical skill for resource management in the healthcare system. We also have Dr. Henry Ochola, a Chevening scholar who did a Master of Science in Epidemiology from the London School of Hygiene and Tropical Medicine, and is dedicated to improving maternal and newborn health through designing, conducting, and interpreting clinical research to understand the causes, the burden, and the impact and prevention of these diseases, especially among women and children. We have Mr. Namboko Gerald, who is also a scholar, Chevening scholar, who completed an MSc in pharmaceutical chemistry at the University of South Wales and focuses on quality control of pharmaceutical products and formulating high-quality medicinal products in Uganda. This is very, very critical, especially at this particular point in time, when as a country, Uganda, we are emphasizing the pharmaceutical industry and emphasizing innovation in pharmaceutical sciences. Different staff have also benefited from the Africa Oxford Initiative at the University of Oxford. For example, Dr. Sarah Nabachwa and Dr. Medad Trinamasko. And these have come back and strengthened research and innovation initiatives here at MAST and strengthening human capital development here at MAST. So basically, the exchange of this research knowledge between MAST and the UK universities increases our exposure to innovative methodologies and to technology, and also facilitates technology transfer back here. So it is very, very crucial, and we hope that we can continue with these partnerships and networks. MAST also maintains institutional partnerships with the University of East Anglia and the University of Edinburgh, and these partnerships facilitate joint research with MAST and faculty exchange programs, basically contributing to the global academic community and global health. These are based in the Faculty of Interdisciplinary Studies and the Faculty of Medicine. As you know, Faculty of Medicine is our largest faculty here, and these partnerships contribute to student exchange, technology transfer, as well as transfer of knowledge back here for training of more junior and younger scientists in the country. Thank you. I'll stop there.
Thank you, Madam Vice Chancellor. Lots of gains there. And that brings us to our other question of how are you looking to sustain these gains made after expiry of the projects, and what is the extent of local collaboration with other Ugandan universities and ministry there to ensure that the gains from these projects get to benefit the rest of the country.
Thank you very much for that question. It's a question of sustainability. Yes.
Life after the project.
Yes, sustainability. Here at MAST, we are always singing sustainability. When a project starts, the moment it starts, we are thinking of sustainability. We don't just start. We plan for the future after the project ends. So one thing I said is that when people are trained, they bring back that knowledge and train others. That is already sustainability. But also, as a country, as a university locally, we are collaborating with our universities here, with the Busitema University, with Makerere University, with Kabale University, so that we have that cross-fertilization across the universities. That is also part of sustainability, because we learn from each other, we transfer knowledge, what we have gained from abroad, we bring it back here. But also we want to thank our government of Uganda, because we are seeing more funding for research and innovation. So through the knowledge we gain from these partnerships, we still bring it back home, and through our funding from government of Uganda, we're able to continue with our research projects as a university. So we are hopeful that the government of Uganda will continue to fund our research projects, so that we can have continuity of the work that we will have started with our partners from abroad. Thank you very much.
Thank you very much. And this brings us finally to, I think, the last question. As a country, how do you think we can further harness the relationship with the UK to strengthen Uganda's expertise in the areas of learning and development?
Okay, as a country, not as a university.
As a country first, and then you can zero in as a university, because MAST is Uganda. Uganda supporting MAST, and Ugandans are benefiting from MAST.
Okay, so I think as a country, we need to strengthen our partnerships with the UK institutions. And I think what we are doing right now is still strengthening, because we are acknowledging the work we have done together, and that is very important. You know, when we are writing publications, there's a section at the end of the publication on acknowledgement. If somebody has done you good and you don't acknowledge them, they will not come back. Yes. So we acknowledge the support they have given us. But I must say that these partnerships have mutual benefit. They're not one way. We benefit from them, they also benefit from us. And if we think that it is only us benefiting from them, then we make a mistake. So we have to strengthen so that we continue to have the mutual benefit. We may not necessarily have the technology that our partners abroad have, but we have a lot for them to learn from when they come here. So once we strengthen chances and opportunities for them to learn from us here, we give them the opportunities to learn, we are strengthening the relationship. So what am I saying? I'm saying we need to strengthen by increasing opportunities both ways. Here locally for them to learn from, and abroad for them, giving us opportunities also to learn from them. We are seeing from the US government the funding cuts. So as a country, we need to increase our own funding, our resources to fund this work, as we also look to our partners to continue funding our work, so that once they see that we also have some effort in funding ourselves, they are also more motivated to continue funding us. But basically, what I'm saying is that the mutual benefit should continue, the student exchange should continue. When the students from abroad come here, they learn a lot from us. Our students also learn a lot when they go abroad, but they also gain a lot of exposure that we may not necessarily have given them here. Exposure in the areas of professionalism, exposure to technology, and so on and so forth. So it's important that we continue to strengthen these partnerships. I'll stop there. Thank you.
Thank you very much, Ms. Chancellor. We appreciate your time and according us this opportunity to speak to us. Thank you very much.
Thank you too.
I'll switch, I think, to Dr. Daniel Olinga.
Yes.
Good morning once again. My name is Gloria. I'll kindly ask you to introduce yourself to us, and you'll be in position to answer the question I'm about to ask, but we'll start with the introduction. Apart from the introduction, my question would be, you're a specialist in emergency health care, which is obviously a big challenge here in Uganda, going by the spate or the number of accidents we get annually, every day, and the lack of routine medical checkups. Start off by telling us exactly how big is the challenge we face in this area as a country, the area of the emergency medicine.
All right. Thank you very much, Gloria. I am Daniel Olinga, lecturer at Mbarara University of Science and Technology, an emergency physician, and the current acting head of department at the Department of Emergency Medicine. So, emergency medicine is relatively a new specialty in the country. Nearly 8 years of existence. That's from academia. Practice-wise, about 5 years. Thanks to COVID, we recognize the need for emergency medicine and the physicians at the department. So it's a broader specialty that starts from the community all the way to the hospital. So when I talk about the community, we are talking about the emergency medicine services, where everyone understands it as ambulance, the first aid given, then the patient is brought to the hospital. In the hospital, we have emergency medicine physicians who are meant to stabilize these patients brought in and then hand them over to the bridging specialty or the primary specialty. So the challenge has been in that angle of handing over these patients. They are received by nurses, interns, and so there is delay in care. You talked about trauma, that is ever increasing. We're having motorists causing lots of accidents, but that's the surgical arm. We also have the medical arm where we have non-communicable diseases ever rising, diabetes, hypertension. Then you also have the infectious diseases, and all these are present with emergencies. So our goal is really to stabilize this patient and then hand them over. So where does the challenge come in? We do not have trained specialists in this angle. The nurses are not trained to handle emergencies. We do not have paramedics in the ambulances to stabilize them before they reach the hospital. And better yet, we have 22 trained emergency medicine physicians in the country. Well, proudly for Mbarara University, we have contributed 18 to that number because we're the initial university to start the master's program in emergency medicine in 2017. So we do not have the human resource. Very many other health workers and different departments are still trying to understand this relatively new specialty, and hence the Ministry of Health is striving hard to ensure that everyone is at par for us to have unison in understanding this care that we give to patients. Thank you.
Working with the Royal College of Emergency to address some of these gaps under the SCALE project. Kindly tell us more about the project and the gains it has delivered for the university and the country. So can I say something maybe before he goes into that question? Yes. Daniel has mentioned that emergency medicine is a relatively new specialty in the country. I think, to put it better, what he wants to say is that the training of emergency medicine physicians is new, relatively new in the country. People have been practicing emergency medicine, but not as a specialized physician training in the country. So Mbarara University initiated the formal training of emergency medicine physicians, and as he has said, has contributed 18 out of the 22. So now we have the programs at Mbarara, at Makerere University, and Makerere University as formal training programs of emergency medicine physicians.
Just responding to the Royal College of Emergency Medicine, the training that started in 2017 was initiated by a fellow from the Royal College of Emergency Medicine, that is UK. So upon his retirement from Uganda. He returned to the UK and told them about the success story in initiating the program in emergency medicine. And this stirred up the interest in supporting the growth of emergency medicine and the emergency medicine care in the nation at large. Like I mentioned to you, the understanding is still ongoing even from the grassroots. So with that, the Royal College of Emergency Medicine reached out to the Permanent Secretary and the Ministry of Health to see how they can actually help. So within this, we created a partnership and a memorandum of understanding that, like the Vice Chancellor had initially mentioned, has specialists and residents, those are the students doing the master's programs, have a bidirectional exchange. We send the specialists to benchmark and understand better how to train, and the residents go for observerships in the emergency departments so that they can come back and translate this understanding back to our nation. But we know these few people cannot accomplish the whole task. So there is a virtual platform where the specialists from UK engage with the specialists from Uganda to reach out to the community through the SCALE program. So this helps to strengthen the health workforce in the grassroots. I will understand how to stabilize someone who has gotten an accident so that they reach the hospital and they can get the appropriate care. So those are the arms that we are currently working on. The other is more British emergency medicine physicians are yet to come back to the country to continue supporting the teaching both at Makerere and Mbarara. Lastly, for the collaborations with the other universities, Gulu University, because Mbarara cannot run out of wheels churning out the emergency medicine physicians, is also starting up emergency medicine program, and they came to Mbarara University to benchmark. So their setting up of the department is being supported by the Royal College of Emergency Medicine. Thank you.
Just to get this clearly, since emergency medicine was formalized as a course or training professionally, pioneered by MAST, do we have only 18 that have been channeled out, or we have more of medics who are doing emergency medicine who have been channeled out by Mbarara? As in the trainees that are now out there trying to address this challenge or to give a solution to this matter. How many have we trained as MAST? Because I remember somewhere you talked of 22 and MAST contributed around 18.
Yes.
We have 18 since the start of this.
Yes, so it is. Yeah, thank you very much.
Program, yes.
Yeah. So we are 7 years old, and there are different numbers that come each year. So we have graduated 18 as Mbarara University. In here, we have Kenyans, Tanzanians, and etc. In total, MAST has graduated 20 to 22, but others are international. So we keep those 18 as the locally made Ugandans, and they are spread out. I'm part of them, so I stayed to support the Department of Emergency Medicine, but we have others who have gone to Mulago, Naguru, and Jinja. Recently, we had those positions filled. Hopefully, we have more. And in training right now, we have 13 emergency medicine residents, with 8 of those being Ugandans. Yes.
Welcome to Dr. Twine. Good morning once again.
Good morning.
You will kindly introduce yourself to us, and you will be answering. My first question is, we all know tuberculosis as one of the 6 killer diseases. From your perspective as a researcher at the Ministry of Health, is TB still a big problem in this country?
A very interesting question, but thank you so much, Gloria, for this conversation. I'm Dr. Twine Daniel. I'm a medical epidemiologist. I'm also a visiting lecturer under the clinical trial training program at Mbarara University. And I'm the vice chair of the National TB Research Forum. I want to say that tuberculosis is still a very big problem. Uganda is still among the 30 high burden countries that are still suffering with the high burden of tuberculosis. We still see almost 198 out of 100,000 TB cases or TB burden that we have in our country, and 6 out of 10 are males. So the males are suffering more, and much of the driving factors is living in slums, both urban slums. And ginger, for example, looking at one country, there's a lot of variation in terms of the burden. Ginger has almost 4 times higher burden of TB than the national burden, and other districts too, Moroto, and even the urban settings of Mbarara. So the burden is still high. We still have also MDR or mild drug resistant tuberculosis. Each year we have about 600 annually treated or diagnosed with mild drug resistance tuberculosis. So the problem is still here with us, and we need to fight it. Yeah.
And my second question would be, you've been working with St. George's University, London, and the Medical Research Council on a research collaboration. What is this about?
Yes, since 2011, we engaged into a collaboration working between Epicenter, Mbarara University, and Mbarara Regional Referral Hospital. That environment is important because the university provides them the research ethics facility that can prepare and support research to happen. And the hospital gives an opportunity for recruitment of patients that we need to test the new drugs that could be useful in improving the outcomes of tuberculosis treatment. And so we began on this effort of looking for shorter treatments for TB, and we know it has been a long journey for developing TB regimens. They started as high as someone taking drugs for over 18 months, coming down to 10 months, 6 months, and we desire to have a shorter treatment. So we started off by optimizing some of the drugs that are within the TB regimen. Normally a person takes 4 different drugs, isoniazid, pyrazinamide, and ethambutol, and then rifampicin for the first 4 months and for the first 2 months, and then they take 2 drugs, a combination of rifampicin and isoniazid, for 4 more extra months. So it's a period of 6 months. 4 drugs in the first 2 months, and then 2 in the remaining 4. It's a big period for someone to be adherent. So some fail, and they can get resistant tuberculosis, and or they can get poor clinical outcomes and die. So we thought that if we shorten the treatment, we might have more people complete and to have good outcomes of TB. So we engaged in that collaboration to promote research in that area with the St. George's University of London. And we started with the first trial, which was assessing an increase of one important drug, rifampicin, by doubling its dose to see if we can have a faster clearance of the organisms out of the lungs, that the organism that cause TB, and to see if we could use that to shorten the treatment. And our first focus was to see if that is safe enough in patients who don't have HIV. And we found it was safe. And we moved into another trial where we now wanted to shorten to 4 months. So where we give one group the normal treatment of 6 months and the normal dose of rifampicin, and then we give another group a double dose of that drug, and we give another group thrice higher dose, because this drug was found generally safe and it could clear the organisms faster. So following that third trial, just as you know, when you're testing drugs, you can either find it effective or not. So we didn't find that there was a difference. And so that takes us back to the drawing board to think again, what more drugs can we bring on board? They could be new, or we can repurpose the old ones. Yeah, so that's where we are, but we have run over a 10-year collaboration, and it has built capacity in clinical trials in regard with TB, and which has evolved into the training I talked about that we began with Mbarara University, Epicenter, and University of Montpellier, which is still running to train more people into how to implement these clinical trials. Yeah.
Thank you very much, Dr. Atwine, for your kind remarks and that informative response. I'll switch now to Dr. Arunga.
Hi.
Welcome.
Thank you.
And Dr. Arunga, I understand your specialty is eye health and care. How big is the challenge of eye disorder in Uganda, and what capacity gaps exist in the treating these problems? Kindly start by introducing this doctor.
Okay. Hi, Gloria. Good morning. My name is Simon Arunga. I am an ophthalmologist and a senior lecturer at Mbarara University of Science and Technology. Also, an honorary assistant professor at the International Center for Eye Health at the London School of Hygiene and Tropical Medicine. So the burden of eye disease in the country is huge. And we have the traditional diseases. What would biggest example being what we call cataract, where the lens of the eye, which is supposed to be very clear, becomes cloudy and the person is no longer able to see well. This comes on with age. But we also have the newcomers or emerging diseases. Biggest example is diabetic eye disease. As you know, globally there is an increase in diabetes and its complications. So one of them being diabetic eye disease, where the back of the eye gets damaged. Now, in terms of the gaps, the WHO, World Health Organization, sets standards and recommendations. So for a country like Uganda, the minimum number of eye experts that are needed should be 200. But currently, we are about 50. So it's still such a huge gap. And what that means, it means the service given is not optimal to the people. Just to give you an example, last year, there was 1.2 million Ugandans who are either blind or they have reduced vision because of cataract. And as a whole country, we were only able to operate 13,000 of those. Really just a drop in an ocean. So that shows you the picture of where we are and what we need to do to really address these problems.
Thank you very much, Dr. Arunga. And you are now going into the realm of applying artificial intelligence in the eye care, working with the University College of London. Tell us more about this and the opportunity it presents for eye care and treatment in Uganda.
So our work has evolved for the last few years as we have had several collaborations with our partners in the UK. Through research, we are not only able to build capacity, but it also has a service component for the people. So how that came about is we had a question of trying to profile how big diabetic eye disease is in the community. So what we set out to do, we went round the biggest part of Uganda in the diabetic clinics, and we were examining the eyes of these patients to try to document how big this problem was. And we were using a technology which allows us to take pictures of the back of the eye. As I mentioned before, we don't have many experts. So what we did, we trained just, basic nurses and young enthusiastic people who are familiar with taking pictures. So they went around taking pictures of the back of the eye, and then we would, as experts, look at these pictures and be able to say this patient needs treatment or not. But that is very manual and not very easy to do. So that set us into a research element of saying, can we use artificial intelligence to be able to trigger and interpret for us these images without necessarily a human being or an expert having to look at the images. So that led to a research of how we can use these images of the back of the eye to be able to apply it with artificial intelligence and make a diagnosis. And just last week, Mbarara University held its big second data science symposium. And this brings together many experts from the artificial intelligence world, policymakers, regulators. And we are proud to showcase for the first time in Africa, we have collected over 60,000 retina images and have developed an artificial intelligence model which can allow automated diagnosis of this condition. So it's a huge leap forward for us as eye care providers, but also in science, for scientists in general. Now, where we are heading into with the University College London is that we have appreciated that the back of the eye or the retina holds other signatures for other diseases like hypertension, like risk of stroke, risk of dementia, and many others. So we are expanding that into what we call an oculomics project, where we'll be using the back of the eye, using artificial intelligence to screen the people. So what that means is that instead of someone from the rural Uganda having to travel all the way to get an MRI scan, for example, with a picture of the back of the eye and an artificial intelligence model, we can be able to tell this person that you are at risk of such and such a disease, so go and get treated. That means that we get better screening for our people. It also means that it is cheaper to screen, and also means that these people can access the timely intervention that they need to have better outcomes. My colleague Daniel talked about emergencies. You don't have to wait to get a stroke. So with this model, the picture of the eye can tell someone that you have a high risk of getting a stroke. So go and get checked and treated earlier.
Okay. Kindly, I understand you've had a collaboration of more than 15 years with a number of UK institutions in the Tropical Health and Education Trust. Tell us more about this collaboration and how beneficial it is to MUST and Uganda generally.
Thank you. So, yes, we've had a very rich and enriching collaboration with a number of UK institutions, and we are really grateful. We are really grateful. And this again started way back with the FET, as you mentioned, Tropical Health Education Trust in the UK, who wanted to join the institutions in the UK with institutions in Uganda. And the theme was shared learning, as the Vice Chancellor said, because there is a lot that our colleagues from the UK learn when they come, because the diseases are different. But there's also a lot we learn when we go. So that collaboration, we've worked with a number of institutions, Bristol Eye Hospital, Moorfields Eye Hospital, and this was under the umbrella of Vision 2020. But embedded in there were capacity building initiatives, excuse me. Some of those which, for example, as the Vice Chancellor said, led to some of us benefiting. I was the first Ugandan to receive a PhD at the London School of Hygiene and Tropical Medicine, and that was paid for by the Queen Elizabeth Diamond Jubilee Trust Fund. Again, coming out of these initiatives. Coming back with that expertise, I've been able to now have other colleagues start their PhD journeys. We currently have 3 colleagues who are doing their PhD, who are ophthalmologists. We've had other colleagues go to London and train. So that becomes more enriching. It's a catalyst. Also, the research brings in a lot of funding and resources to invest. We have some of the state-of-the-art equipment, which were not very easy to resource in a traditional way. What that means ultimately is that we get better patient care because the expertise is there, the infrastructure is there, and that translates into better patient outcomes.
Thank you very much, Dr. Runga. You seem to have a lot of information we could have shared, but because we are running out of time, I'm afraid we are going to stop here. And I would love the Vice Chancellor to summarize everything by my last question in summary. What message do you have for the UK government? And then after that, we will be able to part ways. Thank you very much.
Thank you.
In summary.
Thank you very much, Gloria. Message for the UK government.
Yes.
First and foremost, I want to acknowledge the support they have given us over time and to thank them very much for the support that has contributed immensely to the training and research at Mbarara University of Science and Technology, but also at for the country at large. You can see the products speak for themselves. Emergency medicine, Mbarara University of Science and Technology is leading in training emergency medicine physicians. And this was only possible through the support from UK, and we thank them very much. Simon has also talked about what they're doing in eye health, which is a significant contribution to the country. And of course, with his PhD in hand, he's able to conduct research in eye health and also to train multitudes of ophthalmologists, upcoming ophthalmologists, that will translate to more and more benefit for the country. Daniel likewise has talked about TB, which is a big problem in the country, and him training clinical trialists and conducting research in TB is contributing to reducing the burden of TB in the country, and this translates down to the person at the grassroots. So we want to thank the UK government for this support, and we would like to request them to strengthen the support with us. And as we said, the training has mutual benefit. We have bilateral student exchange programs, bilateral staff exchange programs, and we all learn from each other. So strengthening the collaboration and partnerships has mutual benefit, and therefore would like to see it grow. We'd also like to create more networks and more collaborations. There are many UK institutions out there. We'd like to get more and more of them coming to MUST, Mbarara University of Science and Technology, to collaborate with us, to partner with us in research and training. We still have a lot of research and training gaps that I'm sure could be closed out if we strengthen these networks. Also locally, as Mbarara University of Science and Technology, we collaborate with our sister universities. So strengthening our UK partnerships and networks will also strengthen our local networks with other universities. So that's my message. Thank you very much, and we look forward to the future, a bright future with strengthened and bigger networks and collaborations. Thank you very much.